Thank you very much. First of all, I'm really very sorry that I wish I could be there with you when with my close friends, Yannis Yokovou, Kostas Spargias, Theokofidis, Vlasis, and Apostolos, and other presenters also. But I'm sending you my greetings across the Aegean and from the Turkish Society of Cardiology. Unfortunately, there is an overlap meeting. Now, I will open my presentation. I think now you can see my screen, I think. Yes, okay. My topic is the paravalvular leaks, patient selection, and tips and tricks for optimal treatment. And I will try to be faster. When we look at the current paravalvular leak closure techniques, can be divided as surgical and fully percutaneous, especially for the mitral. And we know that antegrade transseptal and retrograde transfemoral are very, very important fully percutaneous approaches. And what are the 5 important points for selection of a patient for transcatheter paravalvular leak closure? One is the presence or absence of active infective endocarditis. Procedure deferred until completion of intravenous antibiotics and negative blood cultures. And the second one is the intracardiac thrombus or vegetation, because high embolic risk closure only after documented resolution. And the other point is the mechanical prosthetic valve instability, racking valve, because significant dehiscence usually requires surgery rather than catheter-based closure, and unsuitable anatomy, inadequate landing zone, complex multiple defects, or anticipated interference with prosthetic valve leaflets. This is very important. And some prohibitive comorbidities such as limited life expectancy below 6 months. So what are the 5 important points in choosing a technique for transcatheter paravalvular leak closure? One is the mechanism and localization of leak. And when we look at the mitral paravalvular leak mechanism, after the mitral valve surgery, the annulus lost its normal movement and different contraction pattern and dynamics develop, and antiphysiologic movement after mitral valve replacement occurs, and the posterior contraction and anterior tilting. So we always see for example, the most leaks, especially in the anterior and the posterior medial and the posterior region, because in the posterior region, mitral annular calcification is highly seen, especially in elderly persons in this area. It's far from surgical eye, and this region is near the circumflex artery, plus surgeons are using superficial sutures in this area. So this is very important slide for the mechanism of the mitral paravalvular leak, I think. So imaging is very, very important, and the 3D transesophageal echocardiography clearly shows the exact places of the leaks according to the clock method, where the left atrial appendage is at 9 o'clock and the septum is at 3 o'clock and aorta is 12 o'clock, and you can easily find the anterior, anterolateral, medial, posterior medial leaks with a good 3D imaging. And the right anterior oblique view of the fluoroscopy is very, very important, and left anterior oblique caudal view is the mirror of the 3D transesophageal echocardiographic view. So this classification is very, very useful for the crossing and closing the mitral paravalvular leak. The mechanism of aortic paravalvular leak will be different. You know that it's because of the different embryological development. The most important region is the membranous muscular septum between the right coronary cusp and 9 coronary cusp, and a lot of leaks are mostly seen are in this region. And this is a very, very important view of the transthoracic and the opposite view of the transesophageal echocardiography. And we can use the same classification according to the presence of the 9 o'clock position and left atrial appendage. So how we can cross the paravalvular leak? The effect localization is the most important reference point to determine to use antegrade or retrograde technique as a first approach to cross and close mitral paravalvular leak. For the anterior leaks, I always prefer the transseptal antegrade approach. For the posterior leaks, I always begin with transfemoral retrograde. or transeptal antegrade approach with modified pigtail technique. The hardest cases are medial and posterolateral leaks, and I always prefer to start with the transfemoral retrograde approach. Why retrograde access is very important for mitral paravalvular leaks? Many operators prefer transapical approach for posterolateral and especially for medial leaks. However, retrograde access to these localizations is feasible and is a very good alternative. And atrial septal anatomy usually changes after mitral valve replacement and is often challenging. And operators must know retrograde access, especially for creation of arteriovenous wire loop, and creation of arteriovenous wire loop always help to the insertion of larger delivery sheaths. And in cases of peripheral venous abnormality or thrombosis in left atrium, retrograde access is a very good alternative against the transeptal approach. And for medial leaks, regurgitant jet from left ventricle to left atrium usually allows the hydrophilic guide wire to cross the leak easily. The limitations of transapical approach, we know that needs surgical approach and surgical skills, needs hybrid room, not suitable in case of apical scar tissue, and we know that I will show the transapical related complications also. As you see, the hardest cases for percutaneous mitral paravalvular leak closure is the medial leaks, but with this loop and curve maneuver, we can easily cross the medial leak and create an arteriovenous wire loop or not, and we can put the amphitheatre vascular plug device, especially with the usage of the longer delivery system. For the aortic paravalvular leak imaging, we know that transthoracic echocardiography and transesophageal echocardiography is not very good, but CT is very important, as Dr. Reculetis underlined, and also we always use aortography for the imaging of the paravalvular leak. So for the if the leak is right to left or none, we use left anterior oblique for the aortography. If the leak is left to right or none, we can use right anterior oblique, and the none to left or the lateral and none to right, we can use the AP caudal fluoroscopic angles. And the second important point in choosing a technique for transcatheter paravalvular leak closure is presence or absence of a double mechanical valve, because in the presence of a double mechanical valve, the retrograde approach can be problematic. But in cases of double valves, first, I always prefer to begin with antegrade approach. It is easy for the anterior leaks. But if the leak is posterior or posterior medial, I always begin the procedure with antegrade approach by using some modified pigtail techniques to cross the leak. If antegrade approach doesn't work, I always try retrograde crossing, but I always check the blood pressure and think about creation of an arteriovenous wire loop. An AV wire loop also may be useful if the device embolized. Without AV loop, I hesitate to use large delivery catheters, and I always afraid of complications. These are some examples that for the anterior leak, we cross the leak with the antegrade approach with the mother and child technique. And in the second here, as you see, we can cut the distal part of the pigtail and push the Achilles sheath at the bottom of at the top of the left atrium, and we can use this modified pigtail technique to cross the leak. So loop and curve technique in a patient with mechanical aortic prosthesis, but I never directly recommend this technique because of the, there can be some interaction with the mechanical aortic valve, but we had to check the blood pressure and the hemodynamic status of the patient very carefully. The third important point in choosing a technique for transcatheter paravalvular leak closures, leak size and shape. As you see here, some leaks can be round, some can be crescent thick, and some can be slit-like leaks. And for shape of the leak is very important. If the leak is around, we can prefer ADO2 or occlutic double square devices. It's oval. If it is oval, ADO2 or 2 AVP3 or occlutic W square device we can use. But for the crescentic defects, I always prefer to use of the AVP3 or occlutic rectangular W devices. Especially transverse width of the leak and the length of the leak is very important. And if the leak is very large, So usage of large sizes of Octotech rectangular W devices very good for the usage of for the large leaks. And we had to measure the distance of the leak to the wall leaflets also, and we had to try to use the largest device which fits. If there is small distance, we had to use the device with the small rim, and we had always check the gradient across the mitral valve during systole, during paravalvular leak closure. For the device tips, you know that there are two important devices. One is the Amphitheatre family, and the other one the Octotech family. Amphitheatre is not specifically designed for paravalvular leak closure and off-label usage, and morphology of defects represents great diversity, and atrial and ventricular orifice of these defects can be different. However, two discs are in same size in Amphitheatre devices. There are still insufficient data for hemolysis, and new delivery systems are also developed, but the delivery systems are still not compatible with other closure devices. The Octotech family devices are good and specifically designed for paravalvular leak closure, but current delivery systems are not. Great problems through retrograde closure of defects. Designed mainly for transseptal and transseptal delivery system, and now Octotech developed its long 110 cm sheet, and it's working very well when it is appropriately used. And the most important point is the complication risk. And what are the complications related to transseptal puncture? As we know, we had to forward and convergence perforation. Thrombus formation in the system can develop. Thrombus and aerombolism and iatrogenic atrial septal defects. So we had to be careful during integrated approach. Excess site-related complications are present in the retrograde approach, and catheter and wire-related complications during transseptal approach. These are very important for surgical and percutaneous approaches like hemothorax, pseudoaneurysm, left atrial wall dissection, and atrial hematoma, again hemothorax, pericardial tamponade, corneal laceration.
Dr. Kilic?
Cardiac in pseudoaneurysm, so to do retrograde approach instead of transseptal approach for paravalvular. Yes.
There were some short interruptions of sound, but we enjoyed your lecture so much. Could you conclude so we can have one or two questions, and then maybe you can show us a case? I don't know if you can hear us, actually, because I see you frozen.
I'm sorry.
Did you hear us?
I'm sorry. Can you hear me now? Sorry.
Yes, we hear you now, but maybe the internet connection is not optimal. I don't know if you heard what I said.
Yes, I heard.
Perfect. So would you like, is there any question for Dr. Kilic until the...
Unfortunately, I'm sorry about the internet combined with...
Yeah.
So can you see my screen, Apostolos?
We see your screen, but there are interruptions every few seconds. Your internet connection may be not so good. What are we doing?
Sorry. As you see, the device embolization and the endoscopic forceps devices are very useful. Alligator tip devices for catching these devices.
Is this the Raptor? The endoscopic, the bioptome, or the how do you call that device that you retrieve the plug?
This is the endoscopic forceps device from the gastroenterology department. It's called as alligator, and it's very useful. And first we touch the device in order not to be harmful for the left atrial wall, then catch the devices. I use every time this important device, as you see. And another devices like Erno devices are developed, but very expensive, as you knew. So this is my last slide, Apostolos. An interventional cardiologist first understand the mechanism of paravalvular leak development, use the appropriate imaging method for the localization, shape, and diameter of the leak, select the appropriate device, determine the appropriate crossing and closure method before the procedure, and use appropriate crossing and closure equipments, and be aware of complications. These are the articles that we published with the European Paravalvular League Club, and you can really find very good skills from these papers. Thank you very much for your attention.
Thank you very much. Maybe we have one question for you. Are you going to show us the case?
Yes.
How long is the case?
Not very.
Would you do that voiceover? I'm just worried about the connection. That's my only concern.
Yes, it's my chance, I think.
Maybe you can start with the case, and then we see how it goes.
Okay.